I want to invite the president and CEO of, that's right, University of Colorado, Anschutz Medical Center. Did I say that right? Close, okay. Thank you. Chris, come on up. Let's give him a round of applause, please. I was practicing, so it doesn't surprise me that I screwed it up.
Thank you.
Yeah, welcome. So first, tell us about the job that you do. How do you spend your days? What are the sort of tasks of a hospital CEO these days in Colorado?
Well, it's a CEO of an academic medical center, so I spend a lot of time working with our physician leaders to try to create alignment between our organization and their respective departments so that we can work on reducing variation in practice patterns, which we believe is a real driver of improving quality, reducing cost, and also improving patient outcomes.
Mm-hmm. And a hospital CEO told me once that 90% of his job is communicating, and communications is talking. And is that an overstatement? I mean, you just said a big part of what you do is try to get people in alignment.
Yeah, I actually, though, think the big part of communicating for me is listening, not talking. Because for me, I like to get people in a room that have different perspectives on the same topic and really listen hard and understand what would really add value to the patients and families that we serve, and come up with some programs that we can pilot and test with an eye towards scaling those so that we can go from helping a few patients to helping thousands of patients.
Yeah.
So I think communication is extremely important in being clear and candid and making sure you're on the same page with everyone, but being able to listen very attentively to the ideas that the physicians and nurses and other caregivers have, as well as the other staff in the hospital, is probably even more important for someone like me, who's several layers above and maybe not right in the action all the time, seeing what the opportunities really are.
So as you look out the future of your institution and you're considering all of this sort of political turmoil and the federal and the state and the ambition and the uncertainty and all of this sort of moving sands, how comfortable, how confident is the institution that you lead about where it will be in 5-10 years? In other words, are you mostly separate from that political turmoil, or are you pretty connected to it for a range of reasons?
I read a lot about it, and I actually think we're more aligned perhaps than what people read about in the paper. I mean, everybody's about high quality. We certainly embrace the task of providing high quality care in a cost-effective way. Mm-hmm. We understand that we need to be good steward of the resources that have been entrusted to us in this community. So I think there's more alignment maybe than discord. When you're running an academic medical center or any hospital, I think one of the challenges when you think about value-based care and population health is that hospitals tend to not be primary care driven. You know, hospitals tend to be more specialty care driven. And for us to succeed in the new world, we need to flip that and be more primary care driven. Mm-hmm. And establish relationships with primary care physicians in ways that we haven't worked with them before in the recent past. I think if you don't have a primary care base, you don't really have a population to focus on. They are the link to the population. Right now, when you think about specialty care and hospital care, it's fairly episodic. You know, so people come into our lives and we take care of them and then we send them back out. Some people with chronic disease we see more often. But for most of the population, we're a little bit disconnected. And I think for us to really think about total cost of care models, improving quality across populations, we have to become more primary care driven.
So if I had heard a hospital CEO say that 15 or 20 years ago, I would jump to the conclusion that extension to primary care was about generating referral traffic in from the primary care community. Now, more regularly, I hear folks say it's about getting people out of hospitals and keeping them out in the community where at lower cost setting. Is that essentially
Yeah,
what
I think
you're
it's,
speaking to?
I mean, at our hospital, we are full, filled to the gills. So it's certainly not about driving referrals. It's about building relationships so that we can impact patients throughout the continuum of care and not just be an episodic provider.
Yeah.
And I think there's new ways to partner with primary care physicians. And in my experience, one of the best ways is to develop a really strong behavioral health service. And reach into that primary care office and try to partner with them in various ways, either by providing tele options for their patients to provide better access to psychiatry services, or embedding behavioral health professionals right in the practice where you sort of eliminate the stigma of behavioral health and identify anxiety, depression, trauma issues that are with many people much earlier in their progression and then avoid the downstream costs and negative experiences that can be associated with those problems.
How much is, as an academic institution, sometimes this is a little different, but how much is the ongoing challenges of dealing with mental health in the community running into your, how often is that showing up in your hospital and taking up bed space and creating a problem?
I would say daily. So you ask how I spend my time. One of the big challenges we have at the University of Colorado Hospital is we have many patients, that have what we would call excessively long stays. And so for the past 6 months, we've really been focused on those patients because we need the capacity to admit patients that need to be there for medical purposes. A lot of those patients are not benefiting from our care in the hospital anymore. We just don't have a good place to put them. And when you research these patients, a lot of the issues in terms of getting them out and safely reintegrated back into the community are either behavioral health related or more social determinants of health, housing, those types of arrangements, or step-down units, appropriate levels of care that just aren't there for these people. So if you look back the last 6 months, we've been discharging about 50 patients a month that have an average length of stay between them of about 80 days.
Wow.
So if you look at the hospital profile, most patients are out, in less than 5 days. But then there's this group, this tail down there that stays for long periods of time. And, that creates challenges. We're not adding value to those people. We're not really set up for those people to be in our hospital for that long. And it prevents us from helping other people who could benefit from our services. But we just don't have a good solution. So we've been really actively trying to partner with other community organizations that have those type of care arrangements or structures of care to safely take care of those people.
Did I hear you say 50 discharges on average and an average of 80 days?
Each month, we've had a concerted effort to sort of discharge our long stay patients safely and effectively. Yeah. And on average, it's about 50 patients a month since January, and their average length of stay is about 80 days. We just discharged a gentleman the other day that had been in the hospital 765 days.
These are your long stay patients, not all discharges.
These are our long stay patients because there was just no place for him to go in Colorado or who would accept him.
Yeah. So when, as a hospital administrator, workforce is often more of an HR issue, but as part of the academic community and the workforce development pipeline of a medical institution, how do you see the workforce changing to meet the new needs of the future healthcare system? Are you seeing more team-based care happen? Are you seeing folks really just focused at the top of their scope, or how are things changing from your vantage?
Yeah, I see a lot more team-based care. I've been in healthcare for about 30 years, so I think it's evolved to the point where teams are pretty common, multidisciplinary teams. I think most hospitals are very focused on that. I do see opportunities with top of licensure practice, so advanced practitioners in many instances. I think in my experience, the primary care physicians work very well with advanced practitioners and use them to top a scope. Unfortunately, sometimes those advanced practitioners don't have that extra level of training where they can be as helpful for a specialty care physician right out of training. So I think there's a lot more focus on helping advanced practitioners fit into the specialty world and add value and then use them at top of license. So that's sort of a new theme that I've seen.
Good. What, last sort of word here, what advice would you give folks in terms of trying to orient their organizations or their communities towards value in this time of just, a lot of transition? What are the things that you, in your experience, would share with them to do that?
I sort of see the approach to population health or value in 4 areas of concentration. One is the people that have chronic disease, diabetes, heart failure, etc. I think there we really need to focus on pathways, evidence-based pathways, highly collaborative relationships across the continuum between specialists and primary care physicians, because I think a lot of the cost, sits with that group of people. I also see a group that are sort of these long stay patients, where they're stuck in the system, and we need to work on how to address those outliers, focusing more on social determinants, housing, partnering with community organizations. I see the whole primary care prevention focus that you mentioned as another key area, and I see integrating behavioral health into that world to try to improve that clinical outcome of those patients and prevent them from coming into the hospital. I've done a lot of work where we've integrated behavioral health professionals into primary care offices and done side-by-sides where we have them in one office and not in another office. And if you look at the results in terms of downstream costs, it's unbelievable the impact that therapist can have in that practice in terms of reducing downstream emergency room visits, consults to specialists, use of prescription drugs. So it's a highly effective concept in terms of population health. And then the other aspect is alignment of incentives with payers. I think we usually start with that. We usually think that, well, in order for us to do population health, we need capitation, or we need some different type of value-based payment to make that happen. I'm not sure that's the case. I think there are economic incentives that are already out there today that make sense for us to do the right thing for the patient, reduce variation in practice patterns and so forth. I think that's sort of the icing on the cake. If you can come up with a good economic model that's aligned with the payer, that'll add fuel or gas and accelerate the process. But I wouldn't wait for that to happen, because as Dr. Jones articulated very clearly, there's really no perfect system there. There's delays in data. Some people will tell you, capitate the primary care physicians. I used to work at Gessner, which is sort of the integrated financing and delivery system on the East Coast. We had come full circle where we wanted to pay the primary care fee for service, but capitate our specialists, because we wanted the primary care physicians to not refer as much and do more in the office if possible. So I think those payment modules will come and go. I think some of the fundamentals are in those other buckets that I talked to you about.
As you know, and I will just share with everybody else, I appreciate that you were willing to join us. It was real easy asks. Some people are hard asks. Chris was an easy ask. And he's like, so what are we going to talk about? I was like, don't worry about it. We'll make it up as we go along. So thanks for rolling with us. I appreciate it. Let's give Chris Gessner from the University of Colorado Hospital
Appreciate it.
a round of applause. Thanks, sir. Appreciate it.